Oh, it's a pleasure. Thank you so much, Nishant, for giving me this opportunities to talk with the fellows, which I always enjoy. And so, although the VA system has got mostly like a hardcore sick older patients, as you know, I think this is one of the things which we need to keep in our mind. A potential problem which can arise, on and off. So let me see here. Okay, these are my disclosures. So today I will, the overview of my talk will be focusing entirely on the HPS, the his Purkinje system related arrhythmias in general, because I'm just broadly clustering the whole concept of the fascicular VT along with other aspects. So just to have an idea, I think how much the ramifications of the HPS has on these arrhythmias. And one of them being the PVCs we often encounter. And also some of the papillary muscle PVCs often has got some ramification to fascicular system, and as well as some of the challenges what we encounter with induction and mapping and ablation strategies. So this is one of the papers published a while ago by Nogami. And Akiko has published a lot on this aspect from Japan. The Purkinje-related arrhythmias are, broadly categorized into two. One is the monomorphic VT, and another one is the polymorphic VT and ventricular fibrillation. So the most common one, which is actually considered to be the case for a while, which is most exciting part, is the Verapamil sensitive Fascicular VT. And this is one group of categories. We'll get into the details later. That's probably the main part of the talk. And the next is the Purkinje fiber-mediated VT post-infarction, which is actually less spoken about these kind of scenarios, which actually is an important topic to be also considered. Often it can also present with ventricular fibrillation as well. So then the bundle branch re-entry and the interfascicular re-entry, I'm not going to be touching upon on that because it by itself is a huge topic. And we'll talk a little bit on the focal Purkinje VT, which is another entity which can be mistaken for the fascicular VT in terms of Verapamil sensitivity. And the polymorphic is short-coupled variant of the torsade versus ventricular fibrillation. And the VF in the ischemic cardiomyopathy may also be because of some incessant VF, especially when you're going in trying to do an ablation, you tend to see them. And there is a question whether this is a concept which is associated with the CPVT and the early repolarization syndrome. So let's talk about the fascicular VT, which is probably the meat of this particular talk. The characteristics of the fascicular VT is interesting. The first, it was actually described by Zipes back in 1979. And the most important part of the fascicular VT, it is seen in the patients without structural heart disease. That is one thing we need to keep in mind. I mean, that doesn't mean that it doesn't exist in patients with structural heart disease. It's just that it can be present in patients without structural heart disease. And later, Belhassen showed that it is sensitive to Verapamil, and hence it becomes like a Belhassen type of a VT. It was described mainly because of the fact that it is sensitive to Verapamil. So typically it is induced in the ventricular pacing, but the most important thing is like the bundle branch re-entry, it can also be induced from the atrial pacing. So that gives a little bit unique characteristic of being a fascicular VT with induction protocols can be from the atrium or the ventricle. So the right bundle branch block pattern with the left axis configuration, and I will talk about the different kinds later, is the characteristic morphological changes you see with the VT. So broadly, these are the three categories which are seen with the fascicular VT, which is the idiopathic left ventricular VT, in other words. The common ones is the one on the left side, which is the posterior fascicular VT, and it has got a characteristic feature of right bundle morphology with the left axis deviation. And they will get into the little details of the morphological findings in specific group of VTs. The anterior fascicular VT is the next category. The main difference is the axis is high to low as opposed to low to high. And the third category being the upper septal VT. This is often a kind of VT which can be completely mistaken as an SVT, and we need to keep a open mind to really look into this aspect. I mean, it is also true that I think sometimes all these VTs can be mistaken as a VT with, SVT with aberrancy as well. But something we need to keep in mind. As electrophysiologists, I think we are dealing with something different. I think we obviously differentiate, a lot more, but we need to still keep in our mind things can, something be important to keep in mind. So this is the data come from one of the groups in Hyderabad in India. And the interesting data is because they have a lot of fascicular VTs they come through. And the distribution of this type of fascicular VTs among the patients, in the 3 years, what they had was about 57 patients, out of which majority of them, as you can see in this category, were fascicular VTs coming from the posterior fascicle region. There was about 7% from the anterior fascicular group, and some group of patients had both anterior and posterior group in the 2%, and then the upper septal VT was about 2% in the one category. So the majority of the patients what we are dealing is the posterior fascicular VT, which is the common kind of fascicular VT which we encountered here as well. So the conceptual model of fascicular VT is as follows, and we'll go into the details a little bit later as well. So the important thing, in order to have, this is the most important thing, this is a re-entrant form of ventricular tachycardia. So when we talk about re-entrant form, we always know there is an area of slow conduction. That is very important. And in this case, this particular model is showing an area of slow conduction here. And there is a hinge point where it attaches to the fascicle of the patient's conduction system, which is the posterior fascicle in this region, which is depicted. It goes back around and enters into the this area of slow conduction and forms a re-entrant limb. So it exits out further down into the myocardial exit, comes somewhere more apically. So interesting thing aspect, as it is revolving around in this region, there are two hinge points between the two zones, are the zones where it is sensitive to verapamil. We'll actually show you how it can actually say that is the location which is the verapamil sensitive. So typically, when you keep your catheter somewhere in this region, you can see the diastolic potential, which is actually this potential, which looks like a low frequency potential present somewhere there. And subsequently, when it hits this area, you see this fascicular looking potential, which is a much more high frequency potential. And if you have a unipolar catheter sitting somewhere here, which is at the myocardial exit area, you see a QS pattern, but you don't see it when you have a catheter somewhere along this circuit, because we know that is not the site where it is exiting. So in this conceptual model, in the norm, the patient has, for some reason, this particular limb, which is actually mostly the functional limb, which is seeing area of slow conduction, like any other arrhythmias you see in patients without structural heart disease. Normally what happens, the conduction is going from proximal to distal conduction area, and then you have a conduction which is colliding both the anterograde and the posterograde fashion, and hence there is no VT. But we need to obviously perturb the circuit to induce the VT, which actually takes the antegrade limb going through the area of slow conduction through this diastolic corridor, and it turns around in the posterior fascicle and makes this loop to form the common idiopathic left ventricular VT, which is the posterior fascicle fascicular VT. In the upper septal VT, which actually I will kind of combine with both of them from the anterior fascicle VT as well as the upper septal VT. It takes the same channel, but except what it is doing in this case, in the anterior fascicular, it goes retrograde and then comes down through the anterior fascicle as an antegrade limb. But in the case of upper septal VT, it is once again taking the antegrade going backwards in this area of slow conduction it can exit either this way or that way, but it exits somewhere near the his Purkinje system, and hence the QRS is super narrow looking, and also which is confusing for a SVT kind of an arrhythmia. So classically, this is Nogami's very beautiful paper, several papers he has written in the past. You can see in patients with ventricular sinus rhythm. Let's take a look at the sinus rhythm on the right panel. You have, there is a, you always need to have a His catheter that is extremely valuable. And you have a His potential, and you have a fascicular potential going from proximal to distal. And that is depicted as P2 because this is the retrograde limb of most of these tachycardias anyway. The proximal, the antegrade limb, which is the P1, in the case of VT, is going antegrade in the case of the VT, and it turns around retrograde through the fascicular conduction system and forms this re-entrant loop. And this is the exit that is happening in the form of having a QRS, and it turns around, comes back through proximal to distal. And as you can see, this potential is rather low frequency potential in the diastolic corridor compared to the fascicular potential, which is a lot more sharper potential. So the spontaneous reset and Verapamil and decrement, that's an interesting aspect. So one of the things, interesting aspect is when you take a catheter, ablation catheter, you are mapping this one, and you have your catheter sitting in this area of slow conduction. When you pace, you can actually decrement. It almost behaves like an AV nodal conduction type of properties, although it is not quite the AV node, but except the conduction properties can behave like decrement. Now, when you have the measurements here in this upper panel in this right figure, before administration of Verapamil, you can actually see the timings. That is the P1 to P2 interval is 18 milliseconds, and P2 to P1 interval is 287 milliseconds, and then the VT cycle length is 305. After injection of 1.5 milligrams IV of Verapamil, you can see there is a decrement in P2 and P2 and P2 to P1. So, and hence the cycle length is actually, it is decrementing within the fascicular conduction system itself. But it is not decrementing from the QRS to the next sigma, because there is compensatory slowing between the P1 and P2 and P2 to P1. It is not quite the between the fascicular and the QRS, meaning it is not the decremental pore limb which is at the exit area. So that tells you the decrement happens within that zone what I described earlier. So the induction is a very tricky one. So a lot of times, you may not be able to induce. That is one of the things that can happen. Spontaneously, if it happens, it happens in this particular cohort. 11% of the patients spontaneously, the VT was, came on. So one thing to remember is, I think they're very sensitive to sedation. Sometimes you may have to bring the patient when the patient has many episodes during the, of VT happening. That is one of the things, and medications have to be stopped and all these preparations like any other arrhythmias. And this is particularly is very sensitive. So you can induce, in this particular category, RV they were able to induce in 42% of the time, which is actually good. Sometimes it's just a very difficult one to do that. And as you can see, it was induced almost 30% of the patients from the high rate atrium. That means we need to keep that in mind. This is one of the reasons I think we may ignore that this is a fascicular VT. If you don't know particularly, or we are only suspecting this is a fascicular VT, we may think about it. This is something to keep in mind. Sometimes you have to go to the left ventricular side. So you need to use anything possible to really, in terms of location, where we want to pick to induce this VT. So in association pharmacological usage in the form of isopril or sometimes even the phenylephrine seem to be very helpful in this group of patients to induce the VT. The other thing which is noticed, I think there is a paper published from the same group, is among the women in reproductive age group, although this is more commonly seen in men. it looks like it is hormonal dependent. And hence, they have even loaded progesterone to bring the patient during the time of induction of VT. It seems to be associated with cycles. I think history gives away some clues, as far as what you can do in order to induce the VT in the laboratory. So Suraj Kappa actually has shown in this particular, sometimes when you have the VT, you may actually end up on the false tendon and the LV. So this tells you, we all know that false tendon is a structure where often there is his Purkinje system traversing through this the bundle, and hence an important thing to keep in mind, intracardiac echo may be beneficial in a case if there is any obvious false tendon as a potential target for ablation in this group of patients. So just to give you what exactly the false tendon, how it looks like. So it can be attached to the papillary muscle like this as a bridge. It can be attached to any structure from across the ventricle too. And you can see how this is there, and one of our autopsy series. And this is to show in the intracardiac echo how it is extremely valuable to locate this particular false tendon in order to see and categorize, so that you can actually target that specific site. It becomes easier. Often it may be the reason why it may be difficult to ablate unless you find the structure. So in this conceptual model by Nogami, once again, he has shown this both the anterior fascicular and the posterior fascicular circuits. So this is the circuit which is actually showing false tendon as a bridge between the slow and the fast conduction side. So it could be this is location that we may have to ablate. But I think you can take this slow conduction zone where you can target this area, which is the diastolic corridor, in order to have the VT terminate. So this is something we can keep that in mind, and it becomes a nice target, anatomical target, when you have a false tendon, because I think that may be a part of it, and you can specifically visualize the target where you can actually go and do an ablation. So this is once again the interesting concept what we described earlier between the sinus rhythm and the posterofascicular VT. But in the case of upper septal, we kind of I was telling you about that. It is going retrograde. The P1 is the area of the slow limb, which is going retrograde, and P2 is coming downwards, which is the antegrade limb. So, and hence, you can actually see the different type of VT, and the target in the case of the posterofascicular VT is somewhere in this broad area in the basal. I will talk about the targets where else you can do in the RAO and the LAO view towards the septal area. On the other hand, the target for the upper septal VT can be anywhere in this region, where you can actually find this area of slow conduction. You can pretty much target us in this very similar location. It's a broad area. We can actually get into the details. There was one paper published by Ma just a couple of years ago. It's actually a very interesting paper for the fact they got into the details to see which is the best site to really go after the ablation. So we all know one of the things that happens, we talked about the upper septal VT, where because of the, the QRS gets very narrow as it is very proximal. If you just conceptualize the idea that as the fascicular system, the conduction through the fascicular system going downwards towards the exit area, if it's further distal, that means the myocardial involvement is further distal, the QRS tends to get wide. If you keep that in mind, proximal is narrow, distal is wide, that gets you an idea based on how the QRS is looking during the VT, that you can potentially go towards that particular site. And as the HV, his catheter is a very important catheter to have in this particular group of VTs. Let's say if it's a bundle branch reentry VT, it is useful. You all know that HV gets really long. And on the contrary, in this case, the HV, if is rather short, but even with the short HV, there is 3 categories they actually observed in this particular paper. And they found if the HV is greater than 0, In this case, it's 8 milliseconds, as you can see here. And it falls into a very narrow group, which is a proximal site where you can actually consider doing an ablation. It's right there in that location. So there are several things you can see. Sorry for the, I think, probably small picture that you're seeing here. The Purkinje potential to QRS interval is rather large compared to the middle portion, which is about 24 on an average, 34, 24, and 20 in the case of the smaller category. And if you index it to their HV interval, it is somewhat, you can see it gets smaller and smaller as you come down this path. So it's about 60%, 45%, and 30%. That's what it's going to look like. And the QRS duration is very narrow as you go in the proximal side, and it becomes about 128 milliseconds in the mid zone and becomes 140 milliseconds. So overall, the QRS tends to be less than 140 milliseconds in most of the fascicular VTs. You can see that's one of the classical descriptions, which is also been in the literature. So the lead 1 and V6 gives us some information which is very important. As you are more proximal, you tend to have an RS ratio greater than 1. And anywhere in the mid to distal location, it becomes less than 1. So those are the classical features you see with this fascicular VT, apart from the fact that it is a right bundle morphology. In this case, as you can see, the HV is somewhere between 0 and -15. In this case is -6. And the PPQRS is about 28 milliseconds, falls in this middle category. And that's where the ablation will be successful to target. And as you can see, the QRS became wide in this case, which is much more distal location. And the HV is far less than, is about -33 milliseconds here in this case. And it's further distal where it is at the site, almost close to the site of exit, where you can target has the best outcome. One of the observations done from this group in India, what they've seen is the exit, as we know, it almost looks like a protected and exits out further down, apart from the limb, from the circuit which is going around. This area of exit, if you keep your catheter somewhere in this region, the unipolar electrode shows a very nice QS configuration. So is that a good site? Obviously, you are not really targeting the circuit itself, and you are just trying to block the exit area. So it won't be successful. So unipolar in this case may not be very helpful. So what is important to target is this turnaround point, either here or there, where you can actually see different forms of signal, or even you can pretty much go anywhere. But I think this is a nice to really look at it and try to see if you can differentiate. In this case is shown there is a tiny R. As you can see, the exit is further down there in the unipolar signal, and then the bipolar signal shows that Purkinje potential because it is the turnaround point. And this is not as early compared to very proximal region. If you go further down in this area, it will be a lot more early, because that's where it actually, the Purkinje potential will be seen like that. Okay. Then in the case of the slow conduction area, if you keep your catheter down there, then you can see this diastolic potential, which is farther out from the Purkinje potential. That's where it's been described by Nogami very nicely. Ideally speaking, I think the best way to look at these particular arrhythmias is with having a multipolar catheter. That is, I think, probably the ideal. If you can have a catheter going retrogradely along the septum, and when you are ablating, use your transeptal catheter so that you don't accidentally bump. One of the biggest problems with this particular one, if you accidentally bump, you may terminate and you cannot induce it anymore. That is one of the things we need to keep in mind. It has to be very slow. I think it's a good idea to use our ablation catheter to go through transeptal approach, in my mind, to minimize the chance. It can happen even with a multipolar catheter, but at least, if you can slowly get across the the aortic valve along the path and keep it, I think that's probably the best way to handle this. So this is just to show you the example of what we described earlier about locating at the site of exit, which is not the good site for ablation. So you could, what if you cannot induce in the lab? So you can try to see if you can look for these diastolic potentials, or sometimes empirically you need to anatomically go in that area where you can ablate in the mid to posterior septal location of this VT. If you see the VT as we described in Ma's paper, whether it is QRS is fairly wide as opposed to less wide, it may give you some clue, where you potentially want to anatomically target in a situation in a sinus rhythm where you cannot really induce the VT. So this is the example for the successful ablation site. Once you have the successful ablation site, you can actually see this. The limb is actually has a broken circuit, which is the area of slow conduction. It goes down P1. It is separated from the just before how it is present in the VT. Now it is actually kind of merged within there, and now it actually goes out independent of the the normal sinus rhythm after the ablation, where the limb is actually broken. Then you can actually even demonstrate that. This is a very interesting observation that we had. We actually presented in the last Heart Rhythm Society, in the online version of it. We observed a patient who had a histoplasmosis of the proximal septum. You can see a caseating granuloma here right in this area. And this patient kept having these arrhythmias. Unfortunately, we were never called in the EP. They thought it was SVT, we can manage. This patient was sick in the hospital in the ICU. And the echo actually ironically showed the same lesion what you're seeing right here. And what we saw is all along was a fascicular VT, which is actually ironically upper septal VT. So the question comes up, can it happen in a structurally abnormal heart? This is obviously structurally abnormal heart. So whether or not this inflammation invoked this area, whether it is involving this upper septal his Purkinje system is obviously debatable because we could not study, but it's something to keep in mind that this can happen quite often, where the VT can be quite mistaken unless you can delve into looking into why these arrhythmias are happening in a patient who has something abnormal in the imaging that you have obtained. The other category is the Purkinje-mediated VT in ischemic scar. This is something to keep in mind. This particular patient, I will tell you, very interesting was, it's after modifying everything, substrate, he had channels going through this. There is repeatedly, we saw this pre-potential, very sharp potential. And that was the one, as soon as you touch that, he goes into incessant VT. So it was amazing by the fact that this was so much fascicular associated type of VT, and we had to literally do an ablation, subsequently in this area, like a heavy lesion. So in order to actually terminate this particular VT, this goes on to tell you that apart from the fact that we all know about mapping with late potential, lavas and everything, we need to keep in mind in patients with scar-mediated VTs, the incessant nature of the VT, whether it's a re-entrant form or even ventricular fibrillation, it may be a Purkinje-mediated type of a phenomenon as well. So this has been observed by many people, and Nogami actually in one of the papers actually has also categorized this particular group of patients as well. So fascicular PVCs, before we get into the details of the fascicular PVCs, it is good to really differentiate PVC. You all know probably how to differentiate, but I think it's a good idea to go through this exercise between the aberrancy versus the PVC itself. So you can see typical V1 morphology you see with an aberrancy in the form of a bundle branch block pattern. And in this one atypical form you see with the case of a fascicular type of VT. The QRS is usually greater than 140 milliseconds because this doesn't really specifically involve, even if it involves the his Purkinje system, it doesn't exit right at the proximal region. It takes the normal path of the fascicles. And as we saw that when it exits further down distally, the QRS gets wide. In this case, it passes all through into the myocardium, and there is no specific channel for exit, and hence the QRS is greater than 140 milliseconds, whereas the QRS is far less than 140 milliseconds in the case of fascicular VT. And the ratio here, the V6RS ratio is greater than 1. as opposed to this one is less than 1. Then negative AVR is seen because it is coming through the normal pathway. In this case, in the posterior fascicular being the commonest one, you have a positive AVR. When the 3 out of 4 criteria are present, then you're talking in terms of a fascicular VT. Of course, one of the things you also may see is the VA dissociation, but this depends on the rate of the patient and many factors. You may or may not see it. So it's something to keep in mind, the morphological characteristics. So what the fascicular PVCs associated with the papillary muscles is another group of patients. And you all know that I think there is a challenge always. Fascicular PVCs are challenged for many reasons. One thing, anatomically, it can be challenging as far as where it seems to be arising from. And the second thing is, what are the real targets? So one of the things that I have noticed over a period of time, as well as I think in the literature is also the case, is the intrinsic arc deflection. We all know physiologically, when you look into the intrinsic arc deflection, it tells you that I think the origin to exit side, there is a delay in the conduction. Okay, we are talking in terms of not a structurally abnormal heart, but it is just a papillary muscle associated. So in that case, if if it is brisk, you may be actually dealing with a fascicular mediated type of PVC. So in this case, as you can see, there is a pre-potential, which is a fascicular potential. You may have to target there. Interestingly enough, I have seen that quite often we are focusing on looking at the exit sites, and it may not be the site where we need to ablate. We may have to really track back where it seems to be the case. You may burn and you may do the ablation, it may not successfully terminate. You may have to track back further down in order to find where exactly you want to ablate. So just keep in mind, I think the intrinsic arc deflection may give some clue where sometimes it may be hard to find why we are unable to ablate these VTs or PVCs. In this particular patient that we had, very similar. We looked at the exit site. It is way down into the base of the papillary muscle, and we started tracking back further, and we found this fascicular potential. And it was very interesting. The unipolar was quite late, as you can see. That means that's not the site where the unipolar, if you take the unipolar as the earliest, then you look like you are not in an early spot. But the fascicular potential was clearly the target. And as soon as you ablated it, the PVCs went away. This tells you, and also sometimes you can invoke the VT at the time when you're actually ablating the fascicular, mediated, fascicular PVCs. So in order to understand the difference between the fascicular mediated papillary muscle VT versus the papillary muscle idiopathic PVCs. Usually whenever there is a fascicular mediated, that means there is some form of a limb that is coming in the form of a circuit. So it's quite possible you may end up seeing this re-entrant. I'm using the words carefully because there is another category as well. Re-entrant form of VT, commonly present. So the idiopathic, the PVCs, which are just primarily originating from the muscular component of the papillary muscle, are usually non-sustained, and they are PVCs. They are not entrainable compared to the re-entrant arrhythmias, and they are not inducible by the programmed extra stimuli or the atrial pacing. But anywhere, if it is anywhere involving his Purkinje system, you can do a programmed extra stimuli or the atrial pacing. That's a giveaway in a way to look at it as a re-entrant involving the fascicular conduction system. And they may be responsive to Verapamil because it's a fascicular mediated one, as opposed to not sensitive with fascicular PVC. So outpatient, if we give a little Verapamil as a test, and if it works, it gives you a clue. In a VT, we may be dealing in a patient otherwise in a normal, structurally normal heart. So this is another morphological characteristics we have seen. This is, and I'm sorry for this particular tracing. It's a very small one, just to give you a left posterior fascicle. We kind of described middle fascicle. It's kind of a little bit in between, a little bit the structure morphologically in between the two. Anterior fascicle is high to low, and sometimes it can arise from the left bundle itself. It may take very similar looking morphology as the native conduction system. So whenever there is PVCs involving that, you tend to match with what potentially it can look in that situation. This is a little complicated algorithm which was published by Zhang group, and it's interesting is if you have the potential, what you are seeing is a fascicular potential to the QRS timing, and if you add the HV interval during the time, during the sinus rhythm, and then during the PVCs, and if you actually add them and divide by 2, it will be the same as this one. If those two match, the site of ablation, that's the site of ablation that you need to do, you will have a very good, very high success rate. So it's kind of a complicated algorithm. That means that it doesn't tell you site specific where you are actually going, but it tells you the site will be successful when you do an ablation. But you could tie your algorithm to think about it that way, where you want to really match that way. But one thing when you look back, the morphological characteristics, what we saw, where exactly the QRS and the HV interval fit in, it gives you approximately very similar idea, whether you're in the proximal part of the septum, middle part of the septum, further distal down, then you may be able to just to localize or regionalize that area and use the algorithm and then find these PVCs to ablate. So we all know this was sometimes it's been described that a PVC could be trigger for a polymorphic VT or a ventricular fibrillation. This is one of the categories I think Michel Hasger has described quite a bit, and short coupled fascicular PVC could be one of the targets. So, in this case, you can see there is a clear evidence of a fascicular potential, which actually mediates this particular PVC. That's the one, and causing this polymorphic VT or VF. So, hence you target those, you actually are helping this group of patients who otherwise may have multiple ICD shocks without any help from any medications. So that's the one we need to target in that situation. So the other category, the reason I mentioned earlier was that the re-entrant is common for atrial pacing, but there is another category which is a non-re-entrant form of fascicular tachycardia in the form of an automatic focus or a triggered focus. If you pace, you burst pace and induce, it becomes more like a triggered kind of activity. But if you terminate with a burst pacing, it could be automatic type of rhythm. So you could pace map, and you can morphologically match in this case in a non-re-entrant fascicular because it's a local area what you are dealing. And that group of arrhythmias are also known to occur. In this particular group, about approximately 3% of these fascicular VTs could be in that category. So the mapping and ablation, you are targeting the same fascicular potential. So that's one of the things in this case, what we have seen. And if the other criteria seems like it fits, like a fascicular in the form of morphological characteristics, QRS being relatively narrow compared to the myocardial origin of the PVCs and things like that, then try to think about mapping for the fascicular potential. Sometimes you may have to use a tight, electrode in the form of a very short, like 1 millimeter, like a Noga catheter or some other catheter which actually has very short holes in the way, so you can actually target specific location to find this particular fascicular potential. Ablation catheters are good, but I think most of them can pick up. But I think if you don't, I think that may be a good idea to think in terms of if your mind is thinking, particularly you're targeting this fascicular PVCs or the non-re-entrant form of VT, the etiology being fascicular mediated ones. So this is like the summarizing the Verapamil sensitivity. You can target the diastolic abnormal Purkinje potential. But as I said, I think in that limb, it's a broad area. You can actually, you can actually potentially look into different parts of the limb. You may, if end up doing a posterior fascicular ablation in a sinus rhythm where you cannot really get to it. So sometimes you may have to do that. So the other is the Purkinje-mediated VT in a post-infarction. You look at the diastolic Purkinje potential. In the bundle branch re-entrant VT, you specifically target right or the left bundle. And the intrafascicular re-entry, you can go to one of the fascicles. And the focal Purkinje-mediated VT, you target the presystolic Purkinje potential. So the fascicular VT characteristics, once again to recap, the P1 and P2 recorded in a relatively large area in the mid-septal region. That's one of the things that, some things to keep in mind. Remember one thing, bumping and terminating is one of the biggest problems you encounter, and as gentle as possible, as slow as possible to move the catheters will help you to record these particular group of potentials nicely. The entrainment from the ventricle capturing orthodromically and resetting the tachycardia gives away. That's one of the things that you see with particular slow limb because it's going orthodromically. And you can have this decremental areas, as we discussed earlier, between the potential P1, P2, P2, P1, and it is sensitive to Verapamil, and that gives you an idea. But the interval is not the P2 QRS, doesn't change anything. We know that it is not that particular exit area where the problem is. The problem of decrement is also seen with the Verapamil within the limb itself. So that gives you some characteristics of the specific fascicular VT. The success rates are very good. You know, if you ablate this and you know, you can be a lot more confident to say that the chance of recurrence is very small. So the last conclusion being the PVCs and other group of, other than the common idiopathic type of posterior fascicular VT or the other groups of fascicular VTs, is to targeting the Purkinje potential, and PVCs may also be triggering the ventricular fibrillation. You can look at those particular group of PVCs, and also the ischemic, as I mentioned. I forgot to put it in that slide. And the non-re-entrant VT may arise from the his Purkinje system as well, as we, you know, it is not necessarily always re-entrant form of arrhythmia. So I think, I hope I kind of summarized and help you to understand what I know this particular group of arrhythmias, which are you know, good group. Now I see that Dr. Talib is here. Now he's written a lot of papers on this aspect. That's amazing. It's a great honor to, you know, talk about his papers in this presentation.
Thank you. That was great. Fantastic review. So maybe I can ask a few questions here. There seems to be a sense that, you know, non-inducibility can make some of this difficult. So let me ask you sequentially a few things. In setting up the procedures, do you think about using general anesthesia or only conscious sedation for these?
Yeah, I typically try to, have the anesthesiologist, if you are thinking patient is very uncomfortable, available, but I would not possibly start with general anesthesia. Keeping under conscious sedation is probably one of the best ways to approach this one. It's rather short procedure because it's not like extensive, and you might be able to get this done in a short time as the patient. It's our patient comfort, I think will not be a huge issue because of the fact that it's a short one. And yeah, I would target more towards the conscious sedation.
And then if it is non-inducible, I guess there's a couple questions. You talked about pace mapping for the non-re-entrant variety. For re-entrant variety, is there any utility for pace mapping?
Yeah, that's a good question. There are some papers talk about the pace mapping, but it is kind of a little questionable. And I know Dr. Talib can give ideas about this, but I think you can anatomically target the posterior fascicular region because the commonest variety is this one. If you have seen the VT, how the morphology looks like, you could do that. The other one is you could target the diastolic potentials, just the potential itself in this category. You can see it in the sinus rhythm. You might be able to possibly target that particular area. And if you capture very locally with this diastolic potential, you may see the morphology similar to that. It's a very, refined way of, doing the pacing thing, and it requires patience. But I think it is anatomical region in general targeting has been described for years, I think, in the absence of induction of these arrhythmias.
And then for your endpoint, if you do an anatomic line, it's what, shift in axis or?
Shift and axis is particularly if you're targeting the posterior fascicle, you may change the shift and axis. But if you target the diastolic potential, you may not. And once again, that's a tricky question, mainly because of the fact that if you're particularly targeting the diastolic corridor, you may not see that particular anatomical change. And if you're not able to induce, then we are in the same situation. I think overall, it looks like even if you target those areas, it appears like the outcomes are fairly good.
And then you mentioned this association with false tendons. So do you recommend using ice for all of these procedures? Is that a potential target for non-inducible?
Yeah, I would rather consider that. If you, let's say, if you do an echo, transthoracic echo, and you see something ahead of time, you've done for various reasons to assess for structural heart disease, it gives you a clue. If you don't see anything, obviously you don't know what it is. But if you do something, I think that particularly is the cost is an issue for using ice. I think in that case, I think pre-procedure assessment is a good idea. But if you routinely use ice for many ablations in that category, I think it will be extremely valuable in my mind. I use ice all the time, mainly because of the fact anatomically you can target where you are going. Yeah.
And then you're looking for small diastolic potentials. Have you seen any issues with everyone relying on these auto map functions on the systems nowadays?
Yeah, no, I agree. I think this is one of the things I think we still need to keep our eyes open, and because this is a unique group of patients where the primary targets is these low frequency signals. In that case, I think sometimes you have to really because the algorithms have got their own problems. It may or may not. It may filter out. You have to really keep your eyes open to find these targets.